Hello and good afternoon. Welcome to this webinar entitled Managed Care and Homeless Populations, Linking the HCH Community and Their MCO Partners. This is a production of the National Healthcare for the Homeless Council in partnership with UnitedHealthcare and sponsored by HRSA, the Office of National Assistance and Special Population. This session is being recorded. My name is Barbara DiPietro. I'm the Senior Policy Director at the Council. I'm going to be serving as moderator for today's discussion. This is a 1-hour presentation. We will save the last 10 minutes for a question and answer. You'll note that below the presentation slides, there's a chat box for participant questions and any technical issues you might be having. Just type your questions or your issues into that chat box, and we'll provide an answer to you directly. We will get to as many of the questions as possible at the end of the presentation during the Q&A. If you have any technical issues, you should see here, too, that you can call the Council's office at 615-226-2292, and Molly can assist you. This PowerPoint presentation and a recording of the webinar will be posted to our website, and we will circulate a link to everyone who is registered. So at this point, let's get started with the content. Want to introduce our speakers today. We've got a really great range of expertise. We'll start with Catherine Anderson, who is the Vice President of Positioning and Strategy at UnitedHealthcare. And we've got a great panel from Washington State. Doug Bose is the CEO of the United Plan in Washington. We've got Ed Dwyer O'Connor and Matt Lund from Harborview Medical Center in Seattle. And then Rhonda Hoff, who is the Chief Operating Officer and Deputy CEO at Yakima Neighborhood Health in Yakima, Washington. So a good range of projects, both urban and more rural, as well as plans and projects that are working together for some really innovative things. I want to talk just a little bit about what we want to do today. One thing we've learned is that MCOs, managed care plans. Now, I want to be clear that this isn't specific to United plans as one managed care entity. There's lots of managed care entities out there. We wanted really to talk about how managed care works in general and what their interests are in serving people who are homeless and what they're looking for in opportunities to partner with us in the healthcare for the homeless community. And likewise, really the HCH community doesn't often understand how managed care works or what the interests of our partners there are. So this is really a way of introducing two communities to each other who may just want a better chance to understand where the other is coming from. And then this also gives us an opportunity to highlight two really great projects and collaborations that are going on in Washington State and highlight medical respite services. Just to give a little bit of background on where we came in this initiative, we've just released a new policy brief entitled Managed Care and Homeless Populations that tries to outline a lot of what I just described. Last year at the 2015 Annual Healthcare for the Homeless Conference, we realized that there was a lot of unfamiliarity in how managed care works, what the interests were, and then people from plans often were very surprised to learn more about the needs of the patients that we're serving, as well as the model of care that we offer. And that might be a little different than other types of health centers. So really beginning these conversations between each other can enlighten both sides, if we want to talk that way, but then also really begin conversations about how initiatives can be stronger and how we can be better serving the patient population that we're all responsible to. So between the Council and United, we co-wrote the policy brief, and what we're really doing is we're hoping that this begins an ongoing conversation at the local level. We're hoping that this paper gives plans and projects an opportunity to maybe slide something across the table or open up a conversation in a way that maybe hasn't happened before. Or if they have happened, maybe this can help deepen those conversations. We're hoping that these give some good concrete examples of what can happen. But I also want to emphasize that there's many ways that these collaborations can look, not just medical respite care, but a variety of areas. And so we're really encouraging you through this paper and through this conversation to talk between the plans and the HCH community about what might work for you. And so with that, I'm going to turn it over to Catherine to talk about UnitedHealthcare, the national context, a little bit more about managed care and what we can learn from our partners in the insurance managed care industry. So Catherine, I'll turn it over to you.
Great. Thank you, Barbara, and thank you all for joining today. We're very excited about the opportunity to continue this conversation, and as Barbara mentioned, I think there's a lot that we can learn from each other, quite frankly, in both how we think about our day-to-day operations as well as the collaborations and how we can benefit each other. So my goal today is really to lay the groundwork, if you will, on where managed care is and what we are able to do, what we're not able to do, what states are looking for us, et cetera. So with that, I'll go ahead and get started. I know many of you realize that there was significant change, particularly in states that chose to expand Medicaid. Those changes really changed the face of Medicaid for many states and for many managed care organizations as we took on an expansion population. The states, for the most part, along with health plans, really were unsure as to what we would see in that population, particularly in states who hadn't chosen to cover uninsured adults prior to the Medicaid expansion. And so there was a great deal of unknown as states took on expansion. And I would say even now, with a couple years under our belts in some states, there are still learnings that we have in terms of the populations that were included in expansion and what their needs are and how we can best serve them. Most states who chose to expand Medicaid chose to do it under the context of a managed care framework. And that is complementary to what we're seeing, generally speaking, in terms of what states are doing with managed care. More and more states are looking to managed care as the solution for delivering their Medicaid program. And what we're seeing in many states is that it really is expanding well beyond the comfort level of managed care historically for states of covering TANF populations, but really looking to managed care to be the solution for broader populations. Many reasons states are relying on managed care. Primarily the reason that states look to managed care is budget predictability. That's been the case all along, but what we're seeing is that states are now leveraging managed care to get a lot of other things done besides just being able to predict their budget year over year. They're looking to managed care to drive innovations, bring simplicity to the marketplace, as well as in many instances drive transformation within the delivery system. Anyone who's been doing managed care in the Medicaid space for any length of time has had to address social determinants of health. We know there's a broad view of how much it actually impacts an individual's care and their needs, but we typically say safely 40% of healthcare costs are actually driven by non-healthcare needs. And when we look at some populations, namely some of the populations that you may also serve, we know that they can go as high as 75% of their healthcare costs are actually driven by other barriers that are non-healthcare related. And so we have, since the time we started doing managed care, just like all of our colleagues in other organizations, had to address social determinants of health. The difference now, though, is that states are embedding it as an expectation as they develop Medicaid managed care. No longer is it just something a care manager does because it's the right thing to do to help a member of ours, but we're seeing more and more states in their procurement of their programs as well as their contracts having explicit requirements for us to address social determinants, even if those needs are not covered by a Medicaid benefit. Because I'm not sure everyone's understanding of Medicaid managed care, we thought it might be helpful to just give some basic understanding as to how Medicaid managed care is established. And so every Medicaid program is started from expectations from the federal government. The federal government sets forth a framework that all states have to operate their Medicaid programs within. States then take that framework and determine the best way to administer it within their own state, and they can do it specific for individual populations. And through that process, they often seek waivers from the federal government to do things differently for specific populations or for specific geography. That framework of waivers then establishes a multitude of things that include things like being able to use nursing home, what would have been nursing home dollars, to provide community-based services for individuals who qualify. It allows for the use of benefits that are not traditional physical or behavioral health benefits. And it also allows the implementation of Medicaid managed care. Once the state makes a determination to move to Medicaid managed care, the managed care organizations have the ability then to administer the program on behalf of the state. And there are several things that we can do that's different than a fee-for-service program. We do have more flexibility than the state would have on their own, but there are certain limitations that are applied to us as well. There are certain things that we can do. For instance, we have the ability to do things like in lieu of benefits, which allows us to take dollars that would typically been used for traditional health care and use them for non-traditional services, but there are even limitations on those. As we get into some of the Washington experience, my colleague Doug will provide some examples of how we can use this flexibility to meet the needs of our members. As I said, there's been some change in the marketplace and what states are asking of us. There are things that are always going to be present when a state contracts with a managed care organization, and that really is the budget predictability and sustainability. But there's significant shift that's happening at the state level and their expectations of health plans. They are looking for improvements in quality, and there is a pretty broad expanse of how states think and define quality. They're looking for significant improvement in transparency and accountability that doesn't exist in a fee-for-service model. And they're also looking for some of those transformation opportunities, for instance, moving away from paying for volume and looking for paying for value directly to our state partners. And more states are also shifting the way they reimburse managed care organizations to have a significant amount of our payment tied to value as well. And virtually every state that has implemented managed care looks to managed care plans to have person-centered approaches to care, and that really has to be very sensitized to the population that we're serving. And so person-centered care looks different for moms and kids, as an example, as it would look different to a population that's far more vulnerable. And how this all relates then to the conversation today is that we hope that it's helpful to understand what we think and how managed care organizations behave and why we behave the way we do. What are those things that motivate us, and how are we, in some instances, paid and reimbursed and incented through our state partnerships, but hopefully also understanding that while we have broader flexibility, we also have certain limitations. We also hope that today's conversation allows us to look for collaborations and really find partners who can provide specialized services that we should not be creating on our own and therefore duplicating things that already exist in a particular market. The care models have evolved pretty significantly over time. We've been doing managed care for more than 30 years, and I would say when managed care started, it was much more around getting a provider network in place and controlling costs. There is significant difference now in what what the states are expecting of health plans, and where we can look to partnerships like Healthcare for the Homeless to address unique needs of populations that we serve. It's also important to understand that when the state contracts with a managed care entity, and in many states we're seeing more populations included in a single contract, the state has expectations that we're able to care for everybody from newborns all the way through individuals who are at the end of their life, and every stage in between. And because of that breadth, we have the need to look to partnerships to help us address some of the more unique and vulnerable populations. There's also a better understanding, I would say, within the managed care industry that there has to be very unique approaches to serving specific populations. And we know that within that, individuals who are homeless or precariously housed are some of the most challenging for managed care organizations to serve. Other populations that managed care organizations are being asked to care for that are really expanding both the clinical delivery model, but also just how we engage our members, how we look to partnerships with providers to provide services. And those could include populations like individuals who have developmental disabilities, children with special health care needs, individuals who have been part of the criminal justice system. And when you put all of that together, it creates a very comprehensive and complex set of capabilities that we have to develop. We are also being asked to look at how to advance the current system to improve outcomes. Most states are asking us to not just take what they've done in their current fee-for-service environment and carry on. They're asking us to take what's happened in their fee-for-service environment and make it better, which requires us to think more innovatively about how do you deliver services and how do you incent for the right care. We also know that there are certain things that are happening in Medicaid that would help individuals who are homeless or precariously housed that could be really beneficial as programs evolve over time. While the benefits that currently exist in Medicaid are pretty darn fragmented, and there is a significant fragmentation when there's a requirement to coordinate with services outside of the Medicaid benefit, but more and more of that is being required of us. We are also seeing, not just within United, but most of our competitors as well, are appreciating the complexity of doing care coordination for certain populations that is requiring us to be not telephonic, which is the old model, but really be out in markets supporting the needs of individuals where they live and where they seek services. And then these changes are really changing the framework of how Medicaid managed care works and what our state partners expect of us. And we don't see anything changing in the near term, both in terms of the kinds and number of populations that are included in managed care and the expectations of states. In fact, we think states are becoming very savvy purchasers and will be pushing more and more for us to expand services and meet needs and create innovations. All of this creates pretty significant policy considerations. I'll run through a couple of these that I think are probably the most important specific to today's conversation is really first, expansion versus non-expansion. Obviously, states who have chosen not to expand Medicaid, there's very little we can do with that population. But those states that have chosen to expand Medicaid, as we know, there's a variety of ways that that expansion is actually happening. And so because of that, it's very important to understand what the implications are and what some of the nuances of those expansion models would have on a homeless population. An example of that would be states that are putting individual responsibility and using savings accounts as an example of a model to encourage individual accountability to their own health care may be more difficult for certain vulnerable populations to manage than others. And that's very important as states think about the policy related to that. There are also significant things that tie our hands, and that falls in the benefits category, and making sure that as states consider developing a managed care program, that they're doing it in such a way that provides us the broadest opportunity to have flexibility and to serve the needs of individuals regardless of what those needs are, and also to be able to jump across the Medicaid lines to other programs seamlessly so that there isn't a duplication of services and that we're able to truly meet the individual's needs. We also need to really understand payment and delivery reforms. Again, states are looking to managed care as a framework to drive these reforms much more quickly than they could do on their own. But those reforms can have pretty significant implications in how care is delivered, who's doing the delivery, how care can be incented, how it can be approved, et cetera. And so it's really important to consider a broad spectrum of policy considerations as programs are designed. We're looking at lots of opportunities to partner. We have had the ability and the pleasure of partnering with Healthcare for the Homeless in a few markets, and it's an example of where I think there's significant ability to leverage the strengths of each organization. It is really inefficient for managed care to create something that someone else is highly specialized in, but that to really leverage those collaborations. And I think that what we've done so far nationally is just scratching the surface, quite frankly. And so I really encourage all of you on the phone to be able to focus on the opportunity to look at what those collaborations might be and appreciate that those collaborations might be different depending on the managed care organization that you're working with. But there are clearly opportunities to improve the care delivered to members. There's opportunity to improve quality and utilization. And then really looking at how do we develop trusted partnerships to innovate with unique skills, and I would say also to really focus on collaboration for the policy advocacy work that's so important to the work that we do for vulnerable populations. And with that, I'll hand it back to Barbara.
Thank you, Catherine. I think this is an opportunity for us, too, to just reflect on all of the possibilities that Catherine had outlined in terms of managed care and what states are expecting now. This is a really good opportunity to talk about social determinants of health. I think this is finally really making its way into the mindset of an expectation of what we're really designing programs to be able to respond to. So I echo everything Catherine said, and I'm just excited to hear more from our Washington panel so that they can do a deeper dive on what this really would look like at a community level. Just to reintroduce the folks that will be speaking, Doug Bowes runs the UnitedHealthcare plan in Washington State. Ed Dwyer-O'Connor runs the downtown programs at Harborview Medical Center, and he's here with Matt Lund, his Director of Contracting. So particularly talking about what do those contracts look like and how can you work this into, again, the operations piece. The devil is always in the details, so everyone knows that. So thinking just through some of those nuts and bolts. And then Rhonda Hoff, who is the Chief Operating Officer and Deputy CEO at Yakima. They'll talk a lot about what their collaboration has looked like with medical respite care, again, as one example of an initiative and partnership that can happen between an HCH and homeless healthcare provider and the managed care plan in their community. Just want to take a brief moment, again, since we've got a lot of people from different sectors on this call, just to talk about what medical respite care is. And you can see on the slide, this is where a lot of times hospitals do not have a safe place for discharge when someone has nowhere to go, and where the general population gets discharged to home for rest or recuperation or for some light medical care. If you are on the street or living in a shelter, the hospital's really got a bind, and this leads to longer lengths of stay, higher costs, as well as just not really being able to care for people in the most appropriate venue. So these projects allow people to do that recovery. Many times when people hear respite, they think of caregiver respite, most often with senior populations, but other vulnerable or disabled populations. This is very different from that, and so we emphasize medical respite care in that short-term residential care, again, focused on this population. And then just to illustrate, this type of initiative and these programs look many different ways. There's about 70 of these programs that we're aware of in the United States. Again, they look very different. They can be in homeless shelters, standalone clinics, within other transitional housing programs, or just generally part of a continuum of care that a community might offer. Hospitals are also very active with this naturally, as are the care plans. And so with that, I'll turn it over to to Doug, to talk about where the plan's perspective is in Washington State and how they came to this partnership. So Doug, I'll turn it over to you.
Oh, thanks, Barbara. Hi, welcome everyone, and I'm happy to be here to present and talk about the Washington Health Plan and what we've done with respite care. UnitedHealth Community Plan is the largest, or third largest Medicaid plan here in Washington. We have over 210,000 members, and we provide face-to-face and telephonic care coordination services for our complex members, and that includes many homeless members as well. Washington, I think, is one of the more innovative states around the country. They have sought reforms and done a number of different things, which include, they were one of the states that did Medicaid expansion and probably one of the largest expansion states around the country. They are moving now towards integrated physical and behavioral health, which has been separated in the state, and that also is including substance use disorder. They literally had 3 different silos of management, and they are moving towards pulling all those together. They also received a state innovation grant a few years back and have been working towards creating accountable communities of health, which are regional communities around the state with the goal of improving the health care of all Washingtonians. Fantastic program that we're involved in. And right now they're awaiting 1115 waiver to push significant other reforms in the delivery system, and that would give them some extra funds to move ahead with those reforms. I think I skipped too far ahead here. So in terms of the health plan journey and how we came to establish this particular program and payment, about 10% of the Apple Healthcare members struggle with homelessness, and that number has somewhat increased. When the Affordable Care Act launched, and they put together what they call in this state Health Plan Finder, which helped Medicaid members enroll much easier than they had previously. Some of the documentation was no longer required. We also had in-person assisters and navigators across the state that helped bring more people into the Medicaid coverage. And those changes made it much easier for homeless individuals who previously, without the need of papers, might have not found their way into the Medicaid system. It did significantly add to our homeless members and the homeless members we're serving. So we had some long-standing relationships, and we were seeing certainly issues around this population, as Barbara said, where they were hospitalized and they really couldn't be discharged to the street. They might have been, someone with a port in them, or IV drug abusers, which would not be taken from a SNF or other places that we might normally discharge someone that was in a medical situation but not really needing inpatient acute hospitalization. We looked around, and Harborview has been a great partner with us in King County around certain transformations. So we look to work with them around a program, medical respite care, for those members that could temporarily go to respite care. And it isn't just about respite care. I know Ed will probably talk more about this, but it's also about getting them connected in the community. It's about some education. It's about potentially helping them with jobs or other sorts of things while they're in respite care versus just a discharge to the street. In terms of making the case internally, we're paying the same that we would pay for a skilled nursing facility. However, this is a different program, and as I said, skilled nursing facilities would not take these members. So it seemed to make a lot of sense, not only in terms of the quality care, but the financial aspect of the care. And then we replicated this with Yakima Neighborhood Health Services, again, another great partner of ours in a more rural area of the state. We do continue to look for ways to improve and coordinate care transition evaluation. And one of the things I will say is we're moving a lot more of what we're doing into the community. So we've hired community health workers around the state. We're going face-to-face to find members. We have also introduced a program around the jails because we see a lot of the homeless people going in and out of the jails in a swinging door sort of way. So we're connecting with them as they go in and leave the jails. So we do continue to look for ways to make improvements in the programs and to help deal with this population. And we are certainly very interested in seeing to it that our members are able to access care and are in a recovery environment. We do expect to see this reduce hospital admissions, improve the health of the members, and we do think that the medical respite will help hit the triple aim, which is really to improve the quality of care, lower the cost of care, and improve our members and patient engagement in their own care. And with that, I think I'm going to pass it to Ed to continue the discussion.
Thanks, Doug. I'm going to talk today about the Edward Thomas House in Seattle, which was founded in 2011. However, we've had respite in Seattle since 1996 when we had 2 programs located in shelters in downtown Seattle. Unfortunately, over time it became apparent with those early respite programs that we weren't able to handle the acuity we wanted to, both behaviorally or medically. And unfortunately, one of them had a clean and sober rule so that a lot of our patients were kicked out of respite for basically for having an illness. And we didn't feel like this was really good for our patients. So folks who in the Seattle area, including Public Health and Harborview and 6 different hospitals, got together and talked about how we could come up with a freestanding unit. And today we have in the freestanding unit at Jefferson Terrace, which is a Seattle Housing Authority and HUD building. So when these folks got together, especially the hospitals, were very concerned about people being in the hospital for long periods of time, receiving IV antibiotics, who were also homeless. So this became a real priority for them. And this, of course, spoke to our desire to provide more high-quality acuity medical care and behavioral care for these patients. So we came up with the concept of having a harm reduction program, and we currently have 34 beds in the program. We wanted to meet the patients from a harm reduction perspective where they are at with their illness, and then use motivational interviewing to help them reduce their use while at respite and potentially even get into treatment and other forms of care. One of the concepts that became apparent was that we needed to braid our funding, so we could not get funding from just one source. We had funding from Public Health through HUD and HRSA, and also local mental illness and drug dependency funding. And now, of course, we have the managed care organizations contributing to the respite funds. So the hospitals really needed this IV antibiotic treatment especially for injection drug users, which was almost exclusively the population that was spending 4 to 6 to 8 weeks in the hospital getting this care that could have been provided in the home if they had a home. So that's one of the areas that we focused on. An overview would be that last year we had 475 patients with an average length of stay of 21 days. Who do we serve? We serve homeless men and women with complex medical and social needs who are too sick for the streets but not sick enough for the hospital. They have many acute medical issues, including a lot of abscesses and infections related to injection drug use. I would say that the majority of our patients in respite today are addicted to heroin, which of course reflects the epidemic that we are currently hearing about in our country. So many of these patients are often on IV antibiotics, often for 4 to 6 weeks. Many have multiple chronic conditions, including COPD, kidney issues, liver, diabetes, cardiac concerns, and cancer. And of course, we have a preponderance of chemical dependency in this population that we serve, and a significant amount of people with psychiatric diagnoses. So for patients to be at this respite, we need for them to be at least independent in mobility. It's okay to have a wheelchair as long as they can get in and out of the wheelchair, but we don't have the bandwidth to take care of people who are bedbound. So that would necessitate probably a transfer to to a nursing facility, a skilled nursing facility, which Doug mentioned, but unfortunately most of our patients would not qualify because of their chemical dependency and or psychiatric diagnoses. So for folks to be in our facility also, their behavior must be safe for the setting, so no threats, no violence, no weapons. Patients must also read and sign a behavioral agreement upon admission, and while at respite, they cannot use drugs on the unit. This does not preclude them from using drugs off the unit, and we really discourage them to use while there, but unfortunately, folks are addicted, and oftentimes we have to help them manage their use while on the unit. But no one to this day has been discharged because they were using drugs, unless it was on the unit. So to be able to serve this much higher acuity, we had to hire a medical director. We have nurse practitioners, registered nurses, medical assistants, mental health practitioners, mental health specialists, custodial care, and a data manager. And this is to meet the higher behavioral and medical acuity that we were seeing. Some of our goals for care include access to entitlements while patients are there, access to primary care, which is set up for more than 85% of our patients while they are in respite, case management services upon discharge, housing if possible, opiate replacement therapy if willing and able, chemical dependency inpatient treatment if willing and able, and anything else we can leverage for the patient while they're there that we think will help with their health upon discharge. I got a quick client story for you, just to sort of highlight the type of patient we see. This one is a little bit of an outlier, but I think you'll understand how we were able to help this gentleman. He was a 58-year-old man who was living homeless for three years on the streets of Seattle when he was referred to the Edward Thomas House at Jefferson Terrace. The referral came from our GI clinic at Harborview, where the patient was found to have blood in his stool during a colonoscopy prep. So he got admitted to Harborview, and during his colonoscopy, while at respite, they found a large mass which was in his colon and was found to be cancerous. Subsequently, the cancerous growth was found to have metastasized, and the patient was referred to oncology for treatment. During all this time, he was continuing to stay at respite. He was started on radiation treatment for his cancer, and during this period, he received daily nursing care for his wounds, coordination of follow-up care, and mental health care, including a visit to our psychiatrist. The nursing staff did daily dressing changes for the patient and provided emotional support for his diagnosis and care. While the patient stayed at the Edward Thomas Care Alliance, and respite staff searched for housing placement and follow-up services for the patient. Due to the serious nature of his illness, the patient was transferred to palliative care, referred to palliative care at Harborview to help manage his symptoms and provide supportive care. The patient also was referred to the Ernestine Anderson House in Seattle for housing placement after his respite stay. The respite mental health team got the patient assessed and scored for his vulnerability and priority placement, and at the end of his stay, he was accepted for placement at Ernestine Anderson House. The patient was discharged from medical respite to his own apartment and continues to be followed by Harborview Palliative Care Services. This case was unusual in that seldom do homeless patients get connected to palliative care and housing in a seamless manner that supports them both medically and emotionally while providing for their basic needs of food and shelter. Medical respite also prevented the patient from bouncing back and forth to emergency departments and inpatient care during his stay, thereby reducing the potential cost of care and resource overutilization. As I said, this was a very long stay, so it is a little bit of an outlier, but it shows what's capable of happening at respite for these very impaired patients. So from our perspective, our approach to partnering with managed care, I will give a little overview on this, and then I'll hand it to Matt to talk about the specifics. So we looked at this from a risk-sharing and collaboration point of view. We really wanted to collaborate with managed care organizations to provide better care for our patients. We also wanted to search for innovative ways to provide that care for these underserved and high-cost patients, particularly our respite folks. We also wanted to manage the whole person and look for leverage points in the triple aim and within the expanded Medicaid environment in Washington State. We wanted to combine both reduce costs and improve outcomes, and we felt that this was a natural outcome of the good care provided at Respite. So we really looked to find some data to take to the managed care organizations when they came to visit us. So we did do one study that looked at 69 of our patients, which 6 months prior to their care at Respite and 6 months after, and we showed a 70% reduction in hospital days 6 months after Respite compared to 6 months prior, and a 57% reduction in inpatient admissions, and also were able to decrease emergency department visits by 10%. So we also just are in process of publishing an article right now that's going to be published in the Journal of Hospital Medicine. It's going to be titled Successful Implementation of Outpatient Parenteral Antimicrobial Therapy, in other words, IV antibiotics, at a medical respite facility for homeless patients. And this particular study is was done by our infectious disease folks at Harborview. And they looked at 53 patients who came to Respite for IV antibiotic therapy and showed an 87% success rate at finishing therapy out of these patients with an average length of stay of 22 days. Each patient showed a $25,000 reduction in cost compared to the hospital, and overall of these patients there was a $1.1 million cost offset from Respite compared to the hospital cost. So now I'd like to hand it over to Matt Lund to go over our contracting with the MCOs. Matt.
Thanks, Ed. So this is Matt Lund. I'm the Director of Contracting for UW Medicine, which is a health system in the Seattle area and includes Harborview Medical Center. I work with Ed with regard to the Edward Thomas House contracting and Medicaid managed care contracting. I also work in contracting with commercial insurance as well as Medicare Advantage and other similar programs. What stood out for us in contracting about this program was that it not only is effective, but it also seems to be in line with a lot of the innovative approaches to healthcare that are now coming to light in this era of healthcare reform. And in moving health systems further into healthcare reform, I think that be it health systems or large insurance companies, everyone's trying to find a way to be innovative and manage the health of the population in such a way that, again, as we said a few times today, achieves the triple aim. And I think this is a program that does that. Armed with this information, we decided that we were going to take this out to the managed care organizations. Again, in Washington State, there are 5 Medicaid managed care organizations, and we're contracted with all 5. We work with all of them pretty closely. But we needed to lay some groundwork first. We have this successful program here, but before we could go out and actually take it on the road in terms of contracting, we needed to make sure that we had some things taken care of. The first is we wanted to be able to get some assurance from our state Medicaid agency in Washington State, that's called the Healthcare Authority, make sure that the Healthcare Authority was on board with this. Whether they'd give their blessing or not, they would at least recognize this as something that was proper for us to be engaging with the managed care organizations. And so we developed an approach both in working with the people that we personally knew at the Healthcare Authority to talk to them about it offline a little bit, and then prepared some more formal documents to bring to them to have a look at. One of the things the Healthcare Authority wanted to know was, well, how is this going to be billed? And we said we weren't sure. So in working with a few other similar programs in the United States, we were brought to the reimbursement code G9006. If anyone is familiar with medical billing and coding, you'll know that this is a code that's not used very often, but it does exist. It's HIPAA compliant. The Healthcare Authority was more than happy for us to use this code. So now when our contracted managed care organizations submit their reports to the Healthcare Authority and they see 9006, the Healthcare Authority knows what it is that the MCOs have paid for, and the MCOs know what we're billing them for when we send them bills. We also needed to make sure that we had a framework for how it was we were actually going to charge for this service. Again, up until now, this was a service that had been largely put together through grant funding, and other bits of the largesse of our hospital system. We wanted to make sure we could keep it afloat, and so we developed in working with our hospital system's revenue cycle group, me and contracting, our utilization management group, and social work departments, we wanted to make sure that we had all of our workflows covered so we could figure out exactly what we needed. And once we had that figured out, we knew that billing this out as a daily charge or a per diem was the way to go. And so we had to go in and add a charge to our charge master, things like that. We really were starting from the ground up with an entirely new service. We then assembled all of our data and analysis to take it back out to the MCOs, who had already been at least partially aware of what was going on with the Edward Thomas House, but we were able to bring them some early data to show that it was having a positive effect. It was reducing readmissions and leading to greater and more positive healthcare outcomes for our patients. It was cost effective in that it lowered the costs, at least of our overhead at Harborview, and it would probably do the same thing for the managed care organizations as well. We also hosted tours of our facility for the managed care organizations so they could come and actually see it, actually look into some of the rooms and see the patients there, see our staff working with patients, learn the proximity to the hospital, not just the hospital, but other services, the bus stops and things like that, and really get a feel for what sort of a setting this is. With all that in line, we then approached the managed care organizations with a pitch for our respite services as an actual contract add-on. And so we then took our sorry about that. We took our program to the to the managed care organizations, discussed possible reimbursement models, and then negotiate our key terms with them. And so far so good. We've been contracted with the managed care organizations now for over a year, and it seems to be something that is working out well for all the plans. And I can address any questions you might have at the Q&A portion. Thank you.
So this is Rhonda, and I'm going to go through these fairly quickly, but we're basically a community health center with 6 sites. And we also have 6 units of respite, and only about 10% of our total population are our homeless population. And so this is just our mothership and our main site. We also have 70 units of permanent supportive housing that we work with. And this is just the site for where our respite care is. We have individual apartments, and then we also, it's located in a site where we have permanent supportive housing in the second part of this complex. This just shows the impact that the Affordable Care Act had on our program. We went from 83% of our population being uninsured in 2013 to 68% last year in 2015 being covered by a Medicaid managed care plan. In terms of our respite activities, our referrals come primarily from either the hospital, our own primary care providers, and the same-day surgery centers. And you can see on the left who our staffing team is, and then also what the nurse does, who does the intake. Because we're a community health center, we have the backing of our primary care providers, dietitians, behavioral health specialists, and then our own in-house pharmacy, as well as our dental staff. But at intake, the nurse typically will go to the hospital as soon as we know that we have a homeless person there so that she can begin the assessment and the intake process. So our patients are seen in the medical respite units. They're seen, the staff determined based on the assessments and the individual needs. We'll provide anything from wound care, counseling, on-site services. We do assessments for SSI and SSDI. We investigate any possible family connections and facilitate connecting them when possible. And then we also start exploring the housing options for when medical respite is ended to make sure that we have a smooth transition. You'll see here that our average was 21 days, and I think that's very similar to what Ed just presented a second ago. So we also have an interdisciplinary team conference that's incorporated for many of our respite patients because they are so high need. And we're planning here to develop an intervention plan to reduce the public costs of predictable emergency room, EMS, ER, jail, and court costs for those patients that have particularly high needs. And in our local continuum of care, we call medical respite emergency shelters so we don't disqualify the patients from being eligible for transitional or permanent supportive housing. And the majority of our patients, we are well within the 30 days, but about a quarter of them are who are most medically fragile. We had our longest length of stay last year for 10 weeks, and that particular patient, we did have to return to a shelter for a few days, and then we moved him into permanent supportive housing shortly after that. But you can see here the reasons, the most common reasons why people are admitted into the respite program. In terms of our outcomes, this chart shows the average charge for a hospital stay in Yakima County. We compared it to depression care or for an average rehab stay, and then it shows the average cost for our particular respite program last year. When we can safely provide quality care for our patients needing medical oversight, we make a huge dent in the public costs associated with hospital utilization. Medical respite has been shown to reduce hospital readmission rates, which reduces the costs even more. The goals of our medical respite program are to reduce readmission rates, prevent unnecessary admissions, and to exit our patients to stable housing. We're not always successful in placing our patients in stable housing because there's just not enough either permanent supportive housing or affordable housing available in our community. We know that there are many health plans that are involved in partnering on supportive housing initiatives. If anybody is interested in starting a project in Yakima, give us a call. So this is our quick story. This is Mr. Santos. He's a patient that we met a few years ago at the YNHS Mission, and he was living and volunteering there in the recycling center, congestive heart failure, and he used to use the hospital emergency room as his source of medical care. The emergency room called us, asked us if we could help him, and so we did. We brought him into medical respite, established care with a PCP, put him in respite to stabilize his diabetes. At the time, his blood sugars were over 500. The staff worked with him to understand his health conditions, help him learn to test his blood sugars regularly, and provided daily oversight. The case managers went with him to start his dialysis appointments. The nurse took him grocery shopping and helped him understand how to make healthy choices on a budget. And after several weeks in respite, we were able to move him into one of our permanent supportive housing units in the same complex. So he has the same case manager and support staff. In 2014, we enrolled Mr. Santos into one of the Medicaid managed care plans, and since then, since establishing his care, he has not been back into the emergency room for care. These chains in this picture are some puzzles that he makes in the community, and the puzzle is to unlink the chains without breaking them. Mr. Santos was in our 40th anniversary video last year, and his last comment in the video was talking about how housing and homeless services changed his life, and his final comment was, "I'm not a homeless guy anymore." And finally, another program that we are involved with several of our health plans is the Health Home Program in Washington State. This targets high-cost Medicaid and dual-eligible clients and provides intensive care coordination and support for high-need patients. We use tools to guide our care coordination like the PHQ-9 depression screen and the patient activation measures for self-management. Last year, we provided health home services to 230 different patients, and 23% of those in our organization were homeless. All of our housing case managers and our healthcare for the homeless staff are certified as health home care coordinators to be able to provide these services to our clients and minimize the number of people involved in their care. Thank you.
Thank you so much. I think that was really an amazing amount of information. I know we had to gloss through so much. I just want to let people know the slides and this audio recording will be posted to our website soon, so you can go back and go over some of the stuff. Particularly, I know the contracting piece is a bit that a lot of people will be interested in. Just want to jump into some of the questions that we got along the way. Let's start with, did you have to get a state Medicaid agency approval or a special waiver for the collaboration between the MCO and the HCH provider on paying for respite? And I guess I'll put that really to the whole Washington crew, but Doug, did you want to start with what approvals needed to get made?
Yeah, we didn't. We just used a different code. We used adult nurse practitioners or registered nurse practitioners to pay for this, which is a similar payment for a day. So we did not need to go through and get a waiver on this.
And then another, oh, I'm sorry, is there anything else to add on that?
Sorry, I would just quickly add, this is Catherine, that each state is different, and so it is important that while there may be a code, the state has to be able to recognize that code in order to capture that cost for the managed care organization. So it is important to involve the state, and I would say Washington's pretty progressive, and not every state is caught up.
Yep. Thank you.
A good point, too, is that we have 50 different Medicaid programs because of the variance across states. So always check with your state and work really actively in any collaboration that you make. One of the things that we were talking about is this type of licensure. So if you're getting paid medical respite as if you were a skilled nursing facility, does it require to get some different kind of licensure? And I'm curious to put that out to the HCHs.
This is Rhonda, and we are not licensed to know.
This is Ed. We're not licensed either.
Yeah, this is the concept really of respite. This is Matt. Is really that this is a home, not a home health. It's a home and community monitoring charge, and so home monitoring charge. So this is care that would essentially be given to people if they're in their own home. It's if they don't have their own home, they're staying at Edward Thomas House. And so that's sort of how that works. We're also essentially connected under our hospital as well, but no specific license for respite.
Got it. I knew that there would be a number of questions about the contracting, and I know, Matt, we had skipped through some of that just in the interest of time. But one question that's come in, is there one MCO contract that fits all MCOs with the rates and services the same across contracts, or are these all negotiated individually with each contract different? And I'm curious just about efficiencies there. And again, I'll put that out. I know it'll be different everywhere, but curious what that contract looks like.
Sure. And so in our situation, that's turned into 5 slightly different contracts. And we drafted up a model contract to propose to the MCOs, and anyone who's familiar with contracting knows there's always going to be a little bit of negotiation. So the terms of each contract are slightly different. The way we set this up is that we have a master agreement with each of these Medicaid MCOs, and we made the Edward Thomas House piece of it an amendment to each of the contracts. So it's a little bit of both. There's a little bit of a one-size-fits-all feel to it, but each one is slightly modified to meet the needs of each of the plans.
And Rhonda, is that the same? That's all the same throughout the state?
I don't know if it's the same because we obviously have not compared contracts.
Okay.
Yeah, we can't do that.
And so I knew that also this would be, so can we talk about just different ways that medical respite can be reimbursed? There's a lot of different mechanisms, and I'm curious if you want to talk to that.
Sure. This is Matt again, and forgive me, I can't get into the specifics of each contract. That's all proprietary information. However, we thought this out in being reimbursed in a couple of main different ways. Either the managed care organization would reimburse us on a per diem basis, or perhaps through some sort of a case rate, maybe a single payment that covers all of the days, and then anything that fits in between there. So that's how we discussed reimbursement of this at Harborview.
And we have, in Yakima, we work with there are 5 different Medicaid managed care plans in Washington, and we have contracts with three of them for respite, and each one looks a little different.
We've got a question here from someone who's working in a permanent supportive housing program. How do you encourage MCOs to support providing home case management for medically fragile or chronically homeless patients who are frequent users, or some of those other care coordination services? And again, I would pitch that to everyone, to include Catherine, because you've got more of a national perspective. So maybe part of this is how you approach the managed care, or again, those additional those additional services that might be the case management or care coordination outside of medical respite, but maybe within a housing program.
Yeah, hey, this is Doug, and I can talk a little bit about that. One of the things that we've come to believe as an organization is that we need to deliver a lot more of the care in the community setting and put, for lack of a better word, feet on the street. So we have hired community health workers throughout the state, and they're literally going and knocking on doors and meeting with members and helping them coordinate their care. We've had tremendous success with that program across Washington. It's one of the first ones that we have initiated in the country for UnitedHealthcare, and we now actually are moving, or have moved, all of our care in that direction. So definitely makes a big difference when you can connect with a member in their home and help them connect with their healthcare system.
So, and this is Rhonda, I guess, one of the things that I would hope is similar to what we're doing, what we're starting to do with respite is, especially in the states where it looks like the supportive housing benefit is going to become a reality, as I mentioned in my earlier comments, is that one of the things that we've done is really tried to minimize, the number of people that are involved with our population. And so our housing case managers and our respite case managers are all the same people. And they're cross-trained also as health home care coordinators. And we were very intentional about doing that so that you don't have, multiple people going in and out of somebody's, apartment unit, and so that the care is coordinated. And so one of the things that, hopefully with the supportive benefit is that as it becomes as incorporated into managed care as we're starting to do with respite, so that you have, a finite number of people that are involved in a homeless person or a formerly homeless person who's in permanent supportive housing's life, because I think it's important because of the issues that they have going on, that you have a finite number of people involved in their lives.
Thank you. We are at our time. We had a number of questions we couldn't get to. We knew this issue would be of interest to the community. Really appreciate everyone who turned out, and I'd like to thank our speakers who brought their expertise, both from Washington and from United National, and just really appreciate them sharing their experience here. This is hopefully the beginning of a conversation. We will be having more events and discussions like this, so really urge you to pay attention to future events. And also just want to say again that this will be archived on our website within a few days, and we will email this out to everyone who is registered. And as soon as we close this in a moment, there will be an evaluation survey that pops up and is mailed to you. Please let us know how this event went and met your questions, but then also what you'd like to see in additional conversations here. And so again, I'd just like to also point you to the additional resources we have, the policy brief, which is posted on the Council's website, as well as if you'd like to learn more about medical respite and some of the tools that can help you develop these programs. We have a number of things on our website there as well. Please feel free to get in touch with us if there's questions that we can answer, and I look forward to additional conversations in the future. So with that, I'd just like to close this meeting and thank you again for coming.